Okay, start again, Elizabeth.
I'm gonna do my
Sorry.
spiel again, if you don't mind. Good morning, everyone. I'm Elizabeth. I'm a master's in education student at William Patterson. I'm doing my practicum here at Hackensack, and I'm going to be talking about central lines. I know we have a lot of new grads here, right? Has anybody ever done a central line dressing? You have, okay. It's okay, we're gonna do it step by step, and feel free to interrupt me, raise your hand if you have any questions, and I'll be willing to help you, and then we'll be doing it step by step together. So the purpose of this lesson and the learning objectives, explain the purpose of central line dressing, demonstrate correct sterile technique, understand proper procedure for central line dressing change, list supplies needed for central lines, describe indications for changing a central line dressing, and then identifying strategies to prevent CLABSIs, which are central line associated blood infections. All right, an overview of central lines. They're large catheters that are inserted in a large vein, typically terminating in the superior vena cava. And these are just to minimize risk of inflammation, irritation, and sclerosis. They're used to deliver TPN, pressors, chemo, so like these very caustic medications to the veins. To give fluid, really great line to give a large amount of fluid in. Blood, we can do apheresis and dialysis through these lines. And then if you're in the ICU, you will see some hemodynamic monitoring happening through that device as well. Some common sites, the brachial, you'll see a lot of IJs, subclavian. Sometimes you'll see a femoral vein central line. Those are more put in for in emergencies. So if you ever see that on your unit, your patient's more stable, we want to get that out as soon as possible, just because of the fem is just a high risk of infection. And then risk of central lines, infections, occlusion, and thrombosis. So changing dressings is extremely important. It maintains a sterile barrier and reduces bacterial growth and minimizes risk of infection at the insertion site. Like I said earlier, that line is going right into your superior vena cava, so we don't want any of that bacteria getting into your bloodstream or into your heart. Dressings prevent CLABSIs, which increase mortality, morbidity, as well as hospital costs. The mortality rate of a CLABSI is 12 to 15%, so that's a nice large number, so we want to minimize that. They also are associated with increased length of hospital stay and hospital costs, and it costs the hospital about $46,000 per CLABSI. So here at Hackensack, you're going to be changing a dressing that's transparent with CHG every 7 days, or unless it's non-occlusive, soiled, or wet. So if you assess that the dressing is compromised, you immediately want to change it. If you have a patient that has a gauze dressing, you want to change it every 48 hours. If it's saturated or compromised, we want to change that a lot quicker. So here's some central lines that are compromised. This one doesn't have the CHG square that we like to see, and there's also some kind of discharge and redness that doesn't look great. We would want to inform our provider about that. You have another dressing that has a lot of tape on it. It looks like people were kind of trying to secure the dressing more instead of changing it, and that's the compromised dressing. So if you ever see that, you want to change it immediately. The next one is a bloody dressing, and we recommend that if the blood goes past that little CHG square, we want to change the dressing. If it's inside the CHG square, there's a little blood, which you'll see sometimes, you want to leave it. If it's outside, you want to change it. If it's actively bleeding, we don't want to take the dressing off sometimes because it will cause more bleeding, so we want to wait for the bleeding to subside as much as possible, and then we can change the dressing. And this is probably the most common situation you'll see is the dressing lifting, and a lot of the times people will just keep putting Tegaderm on it, but that dressing is compromised. We shouldn't be putting just Tegaderm over it, we should be changing the entire dressing out.
For the one that's bleeding, would we apply pressure to it to
Yeah,
stop
you can.
bleeding?
Sometimes you'll see gauze, pressure. There's a lot of different devices if it's really bleeding a lot that you'll see pressure bags. But yeah. But that's if it's like hemorrhaging. If it's bleeding a little bit, then we'll probably put gauze.
Okay.
So supplies needed, a clean surface area. You can grab some purple top wipes, clean your area. Hackensack provides sterile dressing kits, which that will look like that. That should be in your clean supply, as well as if your hands are too big for the sterile gloves provided, you want to get your own sterile gloves, as well as making sure that you have clean gloves. Inside the central dressing kit, we have alcohol swabs, a dressing with the CHG impregnated square, chloroprep stick, skin barrier applicator, gauze, surgical tape, outside packaging. The sterile gloves are size medium to large, so if you have bigger hands, or maybe even smaller hands, you can grab your own gloves that you want. I know a lot of people like to just have their own gloves anyway. a mask for you and the patient, alcohol swabs, and then there's a hand sanitizer for in between taking the dressing off and putting it back on. So preparation, we're going to clean our area. We don't ever want to open sterile supplies on a dirty area. Just take some purple top wipes, scrub the area. While we're waiting for that to dry, you can perform your hand hygiene. And then we want to identify the patient using Hackensack's 3 methods of patient identification, which is their full name, date of birth, and the last 3 digits of their MRN. And then most importantly, we're going to explain the procedure to the patient. They're not really probably going to know what's going on. We don't want to just go in there and not explaining it to them, as well as putting a mask on ourselves and the patient. If the patient is not able to tolerate a mask, we just want to make sure that they're turning away from the insertion site. If they have an IJ or maybe a central line by their chest, you want to make sure that they're just turning kind of that way. So we don't want to get them to breathe onto the site. So the first step, we're going to have clean gloves. We're going to have a mask on, and then we're going to go in and we're going to take the dressing off. So we're going to stabilize the catheter, and we're going to peel the dressing back towards the insertion site, so kind of away from you. If you're pulling the dressing towards you and away from the insertion site, there's a risk for the catheter to come out, so we kind of want to go with the insertion. So you guys can start pretending you have your gloves on, you did your hand hygiene and a mask, and pulling the dressing off. If you need help, let me know too. There's an alcohol swab in the kit too. You want to open it? That could help. Once you have your dressing off, we want to assess the site. Is there redness, swelling? Is it tender? Is there any discharge? And we just want to remember that when we go to document later, as well as telling our provider that there is issues with the insertion site. Okay, next we're going to assemble our sterile field. So when you're taking the package, that blue, this is anything inside here is sterile. So we want to take the top flap and push it out away from ourselves when we're opening it. And then we open the sides and the last part. Once everyone has their kit open, there's inside yours, there's, okay. So this is not sterile beside the gloves, so we're gonna perform our hand hygiene. Before we're touching sterile materials, opening anything sterile, or putting any sterile gloves on, we always wanna make sure we're doing hand hygiene. So I'm gonna put this video on while I demonstrate it as well, so you guys can see a better visual. So you're gonna open it out of the sterile packaging. This is more if you got your own gloves. So you're gonna take your sterile gloves, everyone have some? And you're gonna open and unfold it. And I like to open the top and the bottom just because it prevents the paper from flinging back closed. And then you open. Once you have that, you're gonna grab the folded part with your hand. This is sterile, but this folded part will no longer be sterile. So you're gonna grab it with your non-dominant hand and you're gonna slide your hand inside the glove. Now, if your fingers don't go in all the way, that's okay. We're gonna worry about that when we put the second glove on. We can adjust our fingers. Next, you're gonna take your second glove and you're going to tuck your hand into the flap, kind of like that. And you're gonna put your hand into it. And then once you have your gloves on and your fingers aren't in all the way, you can always just go back and adjust as needed. Okay, next we're gonna go into our kit and we're gonna have our CHG, which here is called Prevantix, and it looks like this. You also have some alcohol swabs. This is more for patients with allergies or for CHG allergies, or if you have a lot of blood or sometimes there's dried blood around the site and you want to clean it up a little more, you can use this, but we really should be using the CHG unless it's contraindicated. So we're going to take that out. We're also going to take a gauze that's in here to stabilize the dressing. Stabilize the catheter, like that. So we're sterile with both hands. And then you want to scrub the site back and forth for 30 seconds. And you just want to make sure while you're scrubbing that you're staying inside and then you're working your way outside. You never want to go outside and come back in just because you're going to be bringing bacteria back into the catheter. So scrub for 30 seconds, and then we're going to allow the site to completely dry. Sometimes you'll see people standing over the site, blowing on it. We don't want to do any of that. Blowing, that's, you're blowing your mouth normal flora into a site. Also fanning, any bacteria that's in the air is going to be fanned into the site. So we just want to let it to dry naturally. Okay, once it's dry, there's a little blue package. It's called Cavalon, or this is like a skin barrier. You could use that if you want, if your patient has sensitive skin. And this is just to protect the patient's skin with the dressing, and it adds like a little sticky component too, so it sticks better. Okay, once we do that, you're gonna take your CHG dressing and you're gonna peel back the top, or the bottom, sorry, like that. And I like to hold it once I peel it back like this, just because sometimes with the sterile gloves and the stickiness, it kind of gets caught up in that. And you wanna make sure that little square that's kind of like orangey yellow, that's a CHG impregnated square, and we wanna make sure it's on top of the insertion site. Oh, that's the top of it. You want to keep that. So this part. So usually like that. So usually there's another flap, but it's okay. So yeah. No, don't be silly. Sorry, we practice. Yep, over it. And once we have a dressing that looks like this, you want to smooth out the edges, and then we can peel back this white piece. And we're gonna not throw that out, we're gonna save that for later. So then it's gonna look like this dressing over here. Once we did that, we're going to be left over with what I like to call the pants. It's this piece. And you're going to peel that off, and I like to place it underneath the catheter to help secure it a little better. Yeah. Yep, right under the lines too. Okay. Once everyone got that, does everyone have the pants on? So there's another piece that is important. It's like little dashes. This is our date sticker, so we're just gonna date it, and we're also gonna initial it. And then I like to put mine right on top of the catheter, like that. Okay. And once we're done with our dressing, we want to document. If we're not documenting in Epic, then it technically did not happen legally. So you want to document the date and time of the dressing change, the condition of the insertion site, what was our assessment earlier when we took the dressing down, what type of dressing applied, was it CHG, was it gauze? If it was a gauze dressing, we need to change it within 48 hours. The patient's pain tolerance, the procedure, was the site tender, were they in pain during any of the dressing, and then any complications, you want to follow up with your provider. And then some key points for sterile technique: never touch the catheter site directly. That's why we want to use that gauze. Keep all sterile items within the sterile field. I like to keep about like a 2-inch barrier at the edge of my sterile field to make sure all my supplies are within that range. If a contamination occurs, just throw the entire packaging out and you can get a new one. Better safe using extra supplies than causing the patient an infection later on. And then avoid fanning and blowing. Like I said, we don't want to be bringing bacteria back into the insertion site. It's going right into our heart. And then check expiration dates on sterile supplies. Sometimes things come up or get lost in translation and it's expired. And technically, if a supply is expired, it's no longer sterile. So we just want to make sure we're looking at that. And if it is expired, tossing it and getting a non-expired kit. And then some tips to prevent CLABSIs: hand hygiene before any catheter contact. Always use gloves when handling lines. Always scrub the hub. Change IV tubing every 96 hours and a cap change every 7 days. Sometimes it's easier to just do a cap change with your dressing because they're both 7 days for changing. Use a CHD dressing when indicated. The gauze dressing is more for if there's any oozing or bleeding at the site, and the CHD prevents infection, and the gauze kind of can harbor bacteria. Daily review of line necessity. If the line is no longer needed, we just want to remove it as soon as possible. Be proactive, telling your provider, hey, I'm only on 1 more day of antibiotics, let's remove the line, maybe we can do a PID. Or we're not on pressors anymore, the patient's about to go home, I don't want to have this patient at risk for a CLABSI anymore. And then educate the families and patients to avoid touching or scratching the site. You'll see patients, it's itchy, they'll just be scratching at it, and we don't want them to be compromising the dressing or getting bacteria on the site. Any questions?
Thank you.
Then I will throw all your stuff out.